Thank you very much, Laurie and Greg, for the invitation to be here today to support you with this important work. What I've got for you is a presentation that's an overview of the changing healthcare and political environment here in Ontario. Think of it as a detailed environmental scan. There's a lot we're going to get through in about 30 minutes, and a lot of it's new. So if at any time anybody has a question or a comment or something that they'd like to say as I go through this, please just put up your hand and I'd be very happy to deal with it as we go along. So for the agenda for my short talk, I thought we'd do a context setting about Ontario's new government and some of the things that are important to them and what motivate them. To talk about that, yes?
Stand a little bit closer to the mic, please.
Of course, sorry. Is that a little bit better? There we go. Now, to talk about the political agenda of the government, you have to also talk about the fiscal position of Ontario, and so we'll touch on that. We'll then review the government's commitment to ending hallway medicine, which is essentially the anchor election promise of Premier Ford. And then we'll get into the meat of the matter, the details of what the government has introduced through Bill 74 and the restructuring of Ontario's healthcare system. And then a little bit on the path forward. If there's one message I'd like to emphasize with you as we go through this, it's that everything you know, everything you think you know, everything that you're used to when it comes to how decisions are made in Ontario's healthcare system, forget it all. Everything's changed. Throw it all out the window. Absolutely everything is different. And after 15 years of one specific party in power and processes and ways of doing things that we've all become accustomed to, that's a hard thing to understand sometimes. But believe me, from my vantage point where we work and in close proximity to Queen's Park, it is the absolute truth. Every single day brings something new and unbelievable, and it's almost like a tornado of change. So the winds are slowly making their way out across the province, and that's, I think, a main reason why we're here today. It goes without saying, Premier Ford's government is a populist government. It's about the people. It's about pocketbook issues. It's about service to people. It's about making things different for individuals. And that's a core theme and the pivot point of everything that they do. Premier Ford was elected rather quickly. Patrick Brown was a Conservative Party leader, and the expectation was that he would lead the Tories into the general election campaign, and for a variety of reasons that didn't come to pass. There was a snap leadership campaign, and Premier Ford won the leadership of the Conservative Party. The election was only a couple months away, and so Premier Ford and his campaign team had precious little time to assemble a concrete political agenda, the likes of which his predecessor had and other political parties were shaping up to do. So the Premier Ford and his party campaigned through the election on a lot of high-level themes. But one theme that, as I said, anchored everything was Ontario's fiscal position. This slide shows you a chart that identifies Ontario's total level of public debt. Ontario has the highest amount of debt of any sub-sovereign jurisdiction in the OECD. You can see here that the line that's important is the red line. It's some $384 billion. That's where we sit as of the previous fiscal year. And that is what is the frame for all their decisions. Not long after the election, the government did two things. In order to pivot from a campaign agenda to one of public policy, it commissioned two reports. One was a report to essentially audit the health of the province's finances. The second was another kind of value for money audit by Ernst & Young about change in public services. What the audit, the report of the Independent Financial Commission of Inquiry found is that Ontario's total real growth in public spending had increased significantly over the tenure of the previous government. But what was very important was that almost all of that spending happened in transfer payment entities. Some 35,000 transfer payment entities is where the spending growth happened in the last 15 years. It also said, when it listened to its Ernst & Young report, that there were a couple of key areas where change in public services was necessary. So we call them ideas from accountants. the power of digital technology to transform public services, the potential in making back office services more efficient, process optimization, workforce optimization, consolidation of transfer payment entities, procurement, means testing. All of these are kind of anchor themes that drove the government through the fall agenda and the fall economic statement. Still, though, just ideas. Now, when we talk about the potential of improving Ontario's financial health and making public services more efficient when it comes to spending, this is a slide that we at the OHA like to use, because what it demonstrates is that even now, with Ontario's public debt the size that it is, even now with the deficit the size that Ontario has, what we have is a very, very, very efficient hospital sector. This is what we call the hospital efficiency dividend, and it's simple math. If you were to bring Ontario spending on hospitals up to the average of all the other provinces combined, you'd have to inject almost $6 billion more into hospital services. Now, we're not saying we should do that. On the contrary, we think this is an amazing accomplishment because it has freed up significant resources for other very important public policy and healthcare priorities. But what it also signals is that we're probably, as a sector, it's a very large sector, I understand that, absolutely, but as a sector, we are getting to the outer limit of our ability to absorb more and more and more inflationary pressure and not see some trade-off decisions. So let's then talk a little about ending hallway healthcare in that context. This is a slide that keeps me up at night. So alternate level of care, I'm sure everyone in the room knows what it is, but just in case there's a few people who don't. Alternate level of care is a patient in a hospital who can't be discharged because he or she is waiting for admission to another more appropriate setting. Long-term care, home care, assisted living, any number of places. The chart shows you that in February of this winter, we hit an all-time high. This number here shows it just below 5,000, but that's the kind of demarcation point that's used through the public reporting system. The actual high water mark was almost 5,100 cases on February 3rd, if you can believe it. That is shocking to me, and it suggests a system in gross imbalance, where the reliance on the hospital sector has become deeper and deeper, and the reason for that is there's simply not enough capacity in other parts of the healthcare system. The chart on the right shows you some key information about where patients in particular are waiting to go, and you can read that for yourself. But what I wanted to draw your attention to is the box on the bottom right. It shows that we see an increasing number of patients with chronic conditions, but also complex conditions related to mental health, addiction, cognitive behavior. So we're seeing a growing number of patients in that particular cohort who also have a more conventional physical health conditions, and that is a powerful trend that also signals a system in gross imbalance. Why are we in this position today? This just didn't happen overnight. Why do we have so many alternate level of care patients? Well, from the OHA's point of view, the reason is quite simple. For almost 30 years, through successive parties in government, starting with the New Democrats, then the Liberals, then the Conservatives, then the Liberals, now the Conservatives, all governments have had a policy of seeking to reduce emphasis on very high-cost acute care settings, and that is absolutely the right public policy objective to achieve. That line along the top is the total number of acute care beds in the province. You can see at one point Ontario had almost 35,000 acute care beds. We now have around 20,000 acute care beds, and then there's a mix of other beds in other classes of hospital, like mental health, complex continuing care, and so on. So the province has about 30,000 beds of all types in place today, but it's had that same number, believe it or not, for like 20 years. And the population of Ontario has grown by 4 or 5 million people over that time frame. Think about that. That's a massive amount of efficiency garnered, but it also suggests a system that's probably at its outer limit in terms of its ability to change and adapt, barring something such as more technological innovation. What successive governments didn't do is invest deliberately, thoughtfully, based on evidence and data in the other parts of the continuum. So from our point of view, they've used the hospital sector like a bit of a piggy bank. That's where they've drawn a lot of resources for. That's what the efficiency dividend shows us. But they didn't live up to their end of the bargain. You know, the government that I worked for years and years ago, the Harris government, decided to build 20,000 new long-term care beds. Those were built, and that was fine. The previous Liberal government decided to emphasize expansion in home care. And it did invest in home care expansion, there's no doubt about it, but in neither case did those investments keep up with patient need and demand. And we've ended up with this situation today. So as the government entered into office, it realized that the causes for hallway healthcare were long-term and systemic in nature, and it's probably going to take time and more systemic solutions in order to resolve it. Again, that's part of the reason why we're all here today. But to do that, you need a bridge strategy. And so through the fall economic statement and now the provincial budget, we know more about what that strategy is. The previous Liberal government invested $187 million in something called a surge strategy, which is an investment in something called transition beds. They're beds that are under the control and operation of the hospital, but they're a lower level of care, and they're focused on alternate level of care patients. They're patients, you know, who may need some rehabilitation, may need some other kinds of services, but they certainly don't need acute care services. There's some 1,100 beds that have been budgeted for thanks to that strategy, and in the fall economic statement, the government added another 90 million, mostly to annualize those beds. What we've suggested as an OHA, working very closely with our home care partners in particular, is that we're now at $250 million in a surge strategy that's supposed to be a temporary safety net. Now, I learned yesterday that the investment has been added to the base budget of Ontario hospitals, but that doesn't mean it always has to be used for these transition beds. So the OHA, along with the home care sector, through the two associations, has said to government, you know, if hospitals are ready, willing, and able with their home care partners or their partners in long-term care, let them use that surge strategy for other innovative purposes. We shouldn't think of it strictly as an investment in hospital beds, which is what it is at risk of becoming. So let's talk a little bit about what the government's long-term solutions start to look like. The OHA has a very good relationship with Dr. Ruben Devlin, who's chair of the Premier's Council on Ending Hallway Healthcare. And during the election campaign, he came to the OHA board and gave a little talk. And the theme was, how will the Ford government end hallway healthcare? And he said, you know, if the Ford government is, Premier Ford, Doug Ford and the PC party are lucky enough to be elected Premier and elected government, that would be their core healthcare priority. But it would be anchored in an appreciation that, from their point of view, the merger of CCACs and LHINs was a mistake. He was just that clear and direct. And he said there would be significant change, structural change, if elected. And boy, did he turn out to be prescient. We now know through the Bill 74, the People's Healthcare Act, that the government is undertaking a massive restructuring of the healthcare system with three intentions in mind. The first is to better facilitate transitions of care, reduce fragmentation and silos, improve access to services and the patient experience. The second is to provide patients, families, and caregivers with 24/7 care navigation. And the third is to improve access to digital tools, including online health records and virtual care options for patients. This is the intent. They've indicated that this will be a phased and iterative process, likely lasting several years. From my point of view, I certainly hope we start to see a more moderate pace if we're ever going to keep up. What does it mean, though? That's the intent. What does it mean? Well, the government has undertaken two major changes within the bill. One is the creation of Ontario Health, a huge new agency, which seeks to integrate the agencies that are noted on the right. So Cancer Care Ontario, Health Quality Ontario, eHealth Ontario, Trillium Gift of Life, all the oversight bodies that support hospitals and other healthcare providers within the system and bring them under one roof. It also dissolves the Local Health System Integration Act, which is repealed in its entirety, and seeks to take the authority of those LHINs and put them under the roof of the agency. The government has positioned this as certainly an agency that will take on the historic accountability responsibilities of LHINs in particular, but it's also positioning the agency as a service provider to the provider community, so providing it with services, functions, supports that are intended to help everyone do their jobs better. It's less about touching the patient and more about supporting the provider and ensuring accountability. Interestingly, Susan Fitzpatrick, the president and CEO of the Toronto Central LHIN, was named the other day as the interim CEO of that agency, and that's a super appointment. Now, let's get it a bit closer to the community and talk about the second part of what Bill 74 is, Ontario Health Teams. Ontario Health Teams are not a corporation, they're not an organization. I'm thinking of them more as a network. Voluntary networks of providers who come together and create a plan to better integrate services within a specific geographic area. It's voluntary, according to government, and as I noted, they intend to phase it in over several years. They've suggested that there might be something like 50, 60, 70 of these networks. They're not entirely clear of how many they aspire to create in the end. They are intended to focus around specific populations. The government has suggested that population cohort of around 300,000 people makes sense to them. And they've been very clear that a network, if it's going to be viable, has to include a range of services across the continuum. A minimum of 3, but the list of potential candidates for participation in the network is very, very diverse, and that's great. You'll see here some of those mandatory services include hospital, primary care, mental health and addictions, home care or community services, long-term care, palliative care in particular. A lot of hospitals, a lot of health providers across the continuum are really working hard right now because they know that the first applications are likely going to be invited very soon. And we've got a little bit of detail on the rollout. And I think that's great. I think if there's mature Ontario Health Teams that have already been developed very, very quickly and the providers are confident in their submission, well, why wouldn't you submit? But I think the message I want to leave with you and other providers is that you have a lot of time, more time than you actually think. When we met with the minister's staff and the public service and talked a lot about the implementation strategies that they've developed, they're starting to consider things like quarterly or semi-annual application processes that open and close, a very dynamic process where applications are made and if you're not successful, feedback's given, and it's a very constructive exercise, all intending to build toward success. This is the concept anyway. So I think that's very wise, but right now there is a lot of activity going on, and my message is, again, there's a lot of time to think this through and ensure local success. This is what the government has indicated is its rollout process. It released a 50, 60, 70-page guidance document within the last 2 weeks. It is the first kind of foray from the ministry into articulating what it would like to see in a successful Ontario Health Team application. The deadline to submit the first self-assessment is May 15th. Selected groups will be invited to submit a full application on June 3rd. The deadline to submit the full application is July 12th. And then the first announcement of Ontario Health Teams, and there's likely only going to be 3, 4, 5, or 6, will be in the fall. From an OHA point of view, this is not about governance. The OHA, as one provider association, believes strongly in collaborative governance models, and options along the continuum for Ontario Health Teams could be everything from simply working together, perhaps the way you already do today, codifying your relationship more directly in service agreements, working in the concept of an organizational alliance, all the way to the concept of single corporate integration. There's lots of options along the continuum, but this is not a governance exercise, and there's lots of flexibility. There's lots of room for many, many diverse models along this range of options. And I've heard that message time and time and time again from the government and the minister herself. So one final word from me then on the path forward. This is the most significant healthcare restructuring in Ontario in decades. As I've tried to emphasize, the bill really just passed a week ago. There's been so much change and it's been so quick. There is a lot of time here to think about this from a local community perspective and come up with the concept and the options that are right for you. This is, though, a chance to reimagine care in your community and how you could do things better without as many third-party intermediaries and without as much third-party oversight. So the ball has been passed directly to you. It's a great opportunity to focus on what matters the most, the patient experience, patient journey, the caregiver experience. And finally, partnerships have never, ever, ever been more important. And at the OHA, we have been preaching a message of humility and communication and listening to hospitals whenever it comes to their engagement with the provider community and conversation and discussion at the local level about the art of the possible. Well, we think it's a big change for us in the provider community and in the association land. Well, it's mammoth change for the public service. There has been significant turnover within the public service at the ministry. So Helen Angus has obviously been appointed deputy. Nancy Naylor, who was associate deputy, has become deputy minister of education. So there's new associate deputies. One of the most effective public servants that we've ever worked with, Melissa Farrell, has taken on a role at St. Joe's Hospital in Hamilton within that health system. So, you know, she's moved on. So there's a lot of transition within the public service. One thing I didn't cover here in the slides, but is part of the story here, is that the ministry plays, you know, a powerful and important role. It always will. We also have Dr. Devlin with the Premier's Council, which advises both the minister and the Premier. And the minister, Dr. Devlin, and the deputy are, you know, close collaborators. I think they're very much in alignment. The kind of handoff between Dr. Devlin's reports and the actions of government are well coordinated and so on. There are also, though, other significant decision makers on healthcare because of the importance of the commitment to ending hallway healthcare elsewhere in government. So the Premier's office is very active in this area, as is Treasury Board. So Treasury Board, for those of you who may not know, it's a ministry that has historically had kind of oversight over public expenditure in year, but its mandate is much, much, much broader under this government. That's been underway since the previous government, but this is really a significant high point and shift. So there's a huge kind of moving constellation of players that are all still finding their feet, but that's important when answering your question. But they are definitely the public service is definitely fully engaged in this exercise and doing its best to drive it forward. I think the rationale is that it starts with what happened 20 years ago with the who does what restructuring under Premier Harris, which is a huge kind of shifting of services and taxing responsibilities between the province and the municipalities. And for a long time, public health and paramedic EMS services have been considered really the domain of the municipalities. So I think governments have been sort of sensitive to that dynamic since then. Well, you know, speaking of change, you know, last week we heard over successive days that there appears to be a plan in place, or an intention anyway, to significantly consolidate the number of EMS units across the province from a very high number to a very large number. It's not clear to me actually what the specific plan or strategy is, but that seems to be underway. The public health changes are another one, where you know, that discussion about changing the number of public health units started under the previous government. It's now obviously come to fruition with the new government through its budget. They've also added, of course, a significant shift in the weighting of expenditure. So it was previously, as I understand it, 70-30 provincial municipal. It's now moving closer to parity, depending on where you are in the province. That's obviously placing a lot of pressure on municipalities. So the OHA does have increasing kind of questions about how we align those two very, very important services in the context of Ontario health teams. But it's the truth is it's an evolving situation. It really, really is, and we'll do our best to help bring some cohesion and alignment to these various initiatives. So the procurement discussion is a great example of the kind of tension and dynamic between Treasury Board and Health. So if you're not kind of fully dialed into this, a kind of memo appeared out of nowhere a couple of weeks ago, essentially pulling the carpet out from the hospital sector when it comes to procurement. It essentially created a whole series of new requirements and changes that were, I would call them massively disruptive. And they were a kind of one-size-fits-all series of changes. They weren't thought through when it comes to the hospital or healthcare environment. So we really put up our hand and said, this is not viable, what you proposed. So we we got that message into the Ministry of Health, and they were definitely receptive to it. We then convened a meeting with all the shared service organizations in the province and Health Pro. And we had a great constructive discussion. We were able to kind of articulate what had to change for those changes that were just proposed in order to get to a more constructive footing. And then we invited in the public service to talk more concretely about what it is they're trying to accomplish. So I think we'll probably get that back on track. And I think there's been an admission that we do really need a hospital and healthcare specific procurement and supply chain approach, even though it may be contained across a kind of overarching theme of procurement change across government. So we may get, it may be the agency that has kind of notional oversight over procurement, but perhaps we have one or two independently governed procurement entities that actually perform the functions that you're asking about. As for, you're talking about governance of hospitals, I take it from your second point? Yeah. So, I mean, the hospital sector has, I think, led by example over the years, starting at a more kind of complicated and different time in the Harris era with the Health Services Restructuring Commission, where the restructuring was obviously not voluntary. But we've seen the number of hospital corporations in the province move from 225 over the years to about 141 today. But from an OHA point of view, the best decisions about merger and integration are made always on a voluntary basis. And it has to be about conditions that are right, that are surfaced and brought forward by the local community, by local leadership, boards, clinical staff, and volunteers, and so on. Those are always what make the right choices when it comes to merger and integration. I think in Northern Ontario there'll be an ongoing discussion about integration that's different than elsewhere in the province, because there are so many smaller entities in the northern part of Ontario, but there is also a very strong culture there of collaboration and collegiality in any event. But that's where I think some of that may play out, but again, strictly on a voluntary basis.